what I want to talk about, and Wendell can give you this perspective as well, is sort of what contributes to actual passage of federal health policy or federal health legislation. And so here's my take on what it takes to get something done to address a problem that needs to be addressed. The first is a strong case for policy change, and I think you've heard from both Sarah and John that there's, and you will hear from Wendell, there's an incredibly strong case to be made to address drug pricing. Oops. Second is the public opinion is in support of policy change, and some of my slides will overlap with what Liz presented on the previous panel, that there is a public cry for change and a public cry to address this issue. The third is that there's well-developed policy options. Are there places for Congress to go? I think we will talk a little bit more about that, and I know Wendell's going to go into depth. There's a bonus if there's state laws or pilots or demonstrations that inform public policy. Sometimes the federal government doesn't move fast enough, and so the states come in and they try to step in and formulate their own policies. That happened with the Affordable Care Act, and which was based on the Massachusetts health law that passed in 2006. Congressional and executive leadership, and I think this is particularly important where there's consensus on policy and where there tends to be more of a case to be made and people agree on what the solutions are, and we'll talk a little bit about that. And then stakeholders engaged in working with policymakers, or they've been marginalized, or they're sort of, they've had their legs cut out from under them. And I think this is where Murray invited me, because I previously, my job before this was working, leading the policy team at Johnson & Johnson. And so talk a little bit about where the industry has been and what their perspective is and their contribution to this debate. And then finally, a window of opportunity, and I think this also matters a lot. Is there what we called in Congress a moving train? Is there a legislative vehicle that's actually moving that you can stick your legislation onto? I mean, ACA was its own vehicle, Medicare Modernization Act was its own vehicle, but is there some place, is there an opportunity for something to actually happen? And so talk a little bit about that as well. So I know Bill used this slide, and I find it particularly compelling looking at the prices. And by the way, I agree with Bill. I don't understand why we're not talking about deficits and why we're not talking about Medicare solvency. So a nod to Bill that I agree that these are issues that we need to address, and for some reason we aren't. But I do think this slide is compelling because it talks about looking at the contribution of price and utilization to overall spending increases, and this is in a per capita basis. Now, if I was wearing my pharma hat, pharma's response to this is, but you don't include the rebates. The rebates aren't included here, you're just looking at list prices. Niall Brennan, who leads the Healthcare Cost Institute, his response is, well, if you make that data available and you tell me what those negotiated prices are, I'm happy to include them in my chart. And then pharma says, okay, well, we still don't like the chart, but we're not giving you our data. So that's the backstory in that chart. I think we have seen, and I think have made a compelling case that drug spending is an issue not just for public, and it's both public and private payers as well as out-of-pocket costs. And I think there's no question that this is an issue that is affecting everybody's pocketbooks, including the cost of employer coverage. Certainly for Medicare, and Medicare in particular has experienced high growth in drug spending. Medicare Part D, the average annual growth rate in spending is 10.3%, and in B, between 2009 and 2016 is 11.1%. So bearing the brunt of a lot of this, and I think that's why we've seen a lot of calls for a greater role in government in setting drug prices, particularly in the public programs. Liz talked a little bit about public opinion. I think this is sort of prong 2 of the case to be made for federal action and what makes it more likely to happen. And she showed that lowering prescription drug prices is a hot issue among Democrats and independents as well as Republicans. It's the most important issue. So in an election where healthcare matters most, drug pricing matters. Top of that is the top of that issue, or the top of that chart. And not only that, and I think this is interesting, that Americans have a fairly sophisticated understanding of what they want to happen in this area. They want more information about list prices in TV ads. They don't want to just look at those ads and not understand what the price is going to be for them out of pocket. They want it to be easier for generic drugs to come to market. And John talked a little bit about some of the gaming that's been going on, and the fact that the public understands what a generic drug is and what that means to their bottom line, I think is compelling. They want the government to negotiate with drug companies to get a lower price for Medicare, an annual out-of-pocket price cost for people with Medicare. And they're in favor of importation, 78% favor importation. What they don't want at the bottom there is for Medicare drug plans to start excluding more drugs. So what they want is, I think, more government intervention, and not just that their drugs won't be covered. And I think that leads to some of the where the Trump administration has been, and I think I have to say they're well-developed policy options. When the blueprint came out, it was impressive, and I really think they had done an incredible job of giving this issue a lot of thought and a lot of really thoughtful proposals in that blueprint. Here's some of the bigger ideas in there. It was ambitious, but unfortunately not all of the ideas have come to fruition. So requiring pharmaceutical companies to include list prices in TV ads is currently held up in courts. The pharmaceutical industry is sued. Modifying the methodology for Part B drug payments, and this is, limiting drug prices to the rate of inflation, and I think Wendell will talk a little bit about that. There's still some play there. Modifying the Part D drug benefit design to include an out-of-pocket cost or out-of-pocket limit. That's currently also under debate and part of what's being discussed in Congress, so we'll leave those there. International price index for Medicare Part B drugs, and that was a question that we're supposed to ask John. Where is that proposal? We don't know, so that gets a question mark. And then the rebate, prohibiting rebates by removing the safe harbor that protects rebate payments made by drug manufacturers to PBMs. Of course, that one ended up not coming out as well, and that was something
coming out last year.
It was supposed to come out last year, and it just never sort of made it to prime time. It was something that the industry actually was in favor of, and I think would have liked to have seen it, but their warning was, you put this rule out there and you have to make sure that you're not just shifting the payments into calling them other names. So now they're not called rebates, they're called something else, but you're still having to pay it back. And I will also say, at the time this rule was under discussion, I was at Johnson & Johnson, and there were plans coming and saying, okay, if this rule goes into effect, you're going to still have to guarantee us the rebate. You're still going to have to give us the money, even if you're not allowed to do so. So we'll just call it something else. So they were trying to sort of rewrite some of those contracts to make sure that they still got their cut. It's really a complicated system, and everybody has their hand out, and I think that's what makes it so difficult. This year, the president's budget, they've taken a new approach. It's sort of a blanket term of like, we'd like to see some bipartisan action. So the White House is sort of shifting a lot of the attention to Congress, which is why I think it's particularly important that Wendell's here to talk about what the House is proposing and some of the differences between the House and the Senate. But it seems like the White House is still interested in this issue and wants to make a difference, but it's going to look towards Congress, I think, to make some of these big changes happen. In the absence of federal legislation, and I think we talked a little bit about this already, last year 33 states enacted over 50 laws to address drug prices, including proposals addressing access and affordability, and this was compared to 45 laws in 28 states in 2018. This year, we've already seen legislation in all of these areas. This includes price commissions, price controls, transparency, some with notice of price increases, some without notice, IP and patent settlements, and importation. 14 states so far have filed bills on importation. Sarah talked about the Maryland and Maine affordability boards. These are areas where states are incredibly active. They're waiting for the federal government, but in the absence of federal government, they're not going to wait. Unfortunately, there's only so much they can do, and they really need a federal solution, which is why, again, it's really important for Congress to act. Now, some represent models for federal legislation. There was already mention of the gag rule on pharmacists, that pharmacists were not allowed to tell patients when there was a cheaper drug available. If they could have paid out of pocket and it would have been cheaper. There was federal legislation that took on that issue, and transparency, I think, is another model legislation, California leading the way there. So now we get to congressional and executive leadership, and there are areas of consensus between the House and the Senate and the administration, most notably in the changes to Part D, with an out-of-pocket cost limit on costs. I think that's represented in the Senate Finance Bill, in the House passed bill that Wendell will talk about, and it's also favored by the administration. In terms of negotiating directly with drug companies to reduce spending for high-priced drugs, I think that's for Medicare and private insurers, that's where the House stands apart and I think is probably the most progressive. That's not something that the Senate has decided to take up. The Senate bill is bipartisan with Senator Grassley as the chair of the Finance Committee and Wyden as the ranking member, but that's not a place that they wanted to go. Inflation limits on Part B and D drugs, also another area of consensus between the three parties here. Full premium and cost-sharing benefits to all low-income subsidy recipients, like can we make the benefits more generous? And I think that's something where, again, the House has taken a stand, but it's not something so far where the Finance Committee and administration has moved. Importation is something the administration has talked about. I think it's interesting that this isn't somewhere where Congress wants to go. Congress tried to take up this issue when I was working in the Senate, and I think just got kicked down so many times that have decided that we'll let the administration take it, but decided not to go there. And then international reference pricing, pegging payments for drugs to prices in other countries, where you see some consensus between the House bill and the administration, but it's not someplace where the Senate wants to go. So there are areas of consensus and a lot of areas of difference. I think this now comes down to timing. Is there enough time to get something done? And, I think that remains to be seen. So moving on to sort of what's the industry response? So you have all of this action happening, a lot of thoughtful legislation out there. So what's the perspective of the industry? And I think, let me put on a hat and tell you basically the perspective that the industry has taken to this debate. I think their first response is, look, medicines are only 14% of total spending. We're a very small part of the healthcare dollar total, and if you really want to solve the problems in the system, you've got to look elsewhere, particularly at hospitals, and sort of pointing the finger to other parts. We're just small. The other, I think, argument is that drug spending growth is in line with other spending in our healthcare system. There's a bit of a blip you can see there in 2014, and that was hepatitis C. When hepatitis C came out, and actually I would say that's probably what launched this whole issue into drug pricing. If not for Gilead and their pricing of hepatitis C, maybe we wouldn't have gone down this road to that extent. I mean, it was such a catalyst for this whole debate. But I think the industry would say, well, now look, we're in line with other spending across the system. The other argument, and I think, and you saw this slide, this was in John's slides as well. Look, the net price is going down. It's almost flat, and it's really the list prices. So if you really want to look at getting at this problem, you needed to look at this split, this shift between, or the gap between list and net prices, and all the middlemen in between. And brand companies really retain only about 63% of the list price spending of medicines, and the rest is going to others in the system, in the supply chain, and why don't we look there for solutions? And to the administration's credit, they have been looking there. They tried to look there. And finally, the industry response to the debate is, let's look at modernizing drug discovery. It's still expensive to bring a drug to market. Can we find ways of promoting and incentivizing generic competition? I think the industry would be in favor of trying to stem some of the abuses, the pay for delay. They ended up on board with the CREATES Act that allows some of the medicines to be provided for biosimilar companies. Promote value-driven care. I think the industry is in favor of some of the outcome-based payment arrangements. I think that they would favor more in that area. However, there are a lot of administrative barriers that restrict information that companies can share with insurers that make these outcome-based arrangements pretty difficult. Let's pass more of the rebates on to consumers. Instead of the rebates spread across the system like peanut butter, let's try to give it to actual patients and let them benefit from the negotiated rates. Address some of the market distortions, and I think this is an area that that doesn't get a lot of attention. The administration has looked into this, but there are market distortions like the 340B drug pricing program, and if anyone here is at an academic medical center and you know that this 340B that was broadened in the Affordable Care Act that allowed a lot more pharmacies and a lot more entities to qualify for drug pricing under, it's essentially the federal supply schedule, which is the VA pricing, but they're not passing those savings on to consumers and saving them. This is a huge revenue now stream for a lot of academic medical centers and others that qualify for this program under the broadened rules. And then finally, the response to some of the international reference pricing is, well, let's improve trade agreements. So, for example, the renegotiated NAFTA agreement, there was a provision that was later taken out that would have required 10 years of data exclusivity for biologic drugs, and that would have applied to Canada and to Mexico. It was stripped out at the last minute, but I think the industry would say if you improve trade agreements and you can sort of try to reduce what the U.S. is paying relative to what others are paying, I think the response to that is, well, you probably can increase what other countries pay, but that doesn't mean you're going to end up reducing what Americans pay. So, revisiting factors that contribute to passage, I think we've all seen that there's a strong case for policy change. There's definitely a public opinion in support of policy change. There are policy options out there. This area is complicated, but as you've seen, people have given this a lot of thought. I'd say 5 years ago, 4 years ago, the proposals were, let's import drug from Canada and government negotiation. I think there's a lot more understanding now of the supply chain, a lot more very sophisticated proposals out there at the state and the federal level. So I think we have the tools to actually address this issue if we want to. Congressional and executive leadership, I gave it a half because, you know, there's some areas of consensus, but, you know, there's still a lot of daylight between some of those proposals. And if everyone's not on the same page, and if the president, I think, if the president came out and said, I want the Pelosi bill and we're going to push this, or if I want the Senate finance bill and we're going to push this through, I think that would make a huge difference. So despite the blueprint and all the work that HHS and the folks there and John and that team have put into it, besides the president tweeting about it, I think he needs to really step up and really push something through if you want to get congressional action. Stakeholders engaged in working with policymakers, I'd say, you know, there was an article this morning in the Wall Street Journal saying that the drug industry had lost its mojo and had they really, they're now not a key player in Congress. I would say I don't quite agree with that. You don't see that legislation is passed. You see that Mitch McConnell is still saying he's not going to bring the Senate finance bill to the floor. I'd say, you know, they might not have everyone sort of on their side, but they've got enough people and they've got the right people that they've been pretty effective. So when you read something that says the drug industry has lost their clout, I'd say I don't know that I agree with that. And then finally, the window of opportunity, and I think this is where Wendell's going to talk about whether or not there's, I'm going to defer to, you know, in terms of what's moving and when, you know, I'm not there anymore, so I'm going to turn that over to Wendell. Let me leave you with the closing thoughts that every system is perfectly designed to get the results that it gets. I think this is particularly true of our drug pricing system. I think you could probably say that about our entire healthcare system. But particularly, you know, it's a complicated system. You know, there were elements of the Part D program and the role that we set up for PBMs that has contributed to the rebate situation, and I think we need to revisit that. I really think that the system as it's designed is clearly not working for patients. And then my last quote, I thought this one was funny. This was by Ronald Reagan. Since we're in California, I've wondered at times what the 10 Commandments would look like if Moses had run them through the U.S. Congress. And so let's see what Wendell has to say, and thanks for the opportunity.